For 5 minutes.
Thank you, Mr. Chairman. I appreciate it. Let me touch on tort reform, medical malpractice just briefly. I heard the testimony about California's plan. Works great for California, but we have had some bills in the past that wanted to take the California model and apply it nationally. One of the problems I have with that coming from Virginia is that California has a comparative negligence model in all of their torts, not just medical malpractice. Virginia is not a comparative negligence state. It's a contributory negligence state. So if you adopt the California model, it's one of the things we have to be careful for in Congress. If we adopt the California model and apply it statewide, we completely reverse 400 years of Virginia law. There are ways to have tort reform without making it one size fits all from Washington, and I think that's probably what most people would want us to do. So we just have to be careful. So if occasionally you see people talking about tort reform and then something happens on the way from here to the floor, you understand why that might occur. But you would agree that tort reform, and I'll ask the gentlelady the question from California, you would agree that tort reform is something that would be helpful in this process as long as we make sure we're not trampling over the general laws of the state.
I totally agree, and I can say, being a practicing physician in California, our Practice Act had been opened, and so I might be analogous to that you always have to, the Pandora can jump in, and many Pandoras jump back in again, out and in. But if it's an access to patient care, if it's not enabling, especially specialists or even primary care, if they want to treat indigents, if they want to treat others, you're lowering their ability to have their own funds that they need, that they have to generate some way. So there's another way. Is it coming from or is it going out of? So I would totally agree that we have to be sensitive to each state, but limiting malpractice is something that needs to be done.
And I would hope that the other respective states would do what California has done, what Virginia has done, what Texas has done. Now, each state has their own model. In Virginia, they've done a great job, and I can't take any credit for it, although I served there. But the doctors and the trial lawyers got together and came up with caps, and sometimes they argue about it, but they come to the legislature generally with a plan of what we want to do. Does the cap need to be raised? Does this need to be changed, et cetera? And they've worked together as opposed to getting into pitched wars, which makes it a lot easier on legislators to figure out, okay, if they're in agreement and they can both live with it, then it's probably makes pretty good sense. And I would encourage the other states to do that as well. Let me ask Mr. Schneiderwind this. Last May, the Office of the Actuary at CMS said that Medicare's Hospital Insurance Trust Fund could be insolvent as soon as 2021 or as late as 2030. Under current law, there is no ability for the program then to pay claims on behalf of seniors. Given these empirical facts, do you acknowledge that if left unaddressed, Medicare's coming insolvency could present an access problem for seniors on Medicare? It's an easy answer.
Well, if it doesn't have the funds to pay claims, it would certainly have an impact on seniors.
Absolutely. On another policy issue, both for you and the AMA, the President's 2015 budget to Congress includes a proposal that would included a proposal that would apply a $25 increase to the Part B deductible in 2018, 2020, and 2022, respectively. For new beneficiaries beginning in 2018, current beneficiaries or near retirees would not be subject to the revised deductible. Has your organization taken a position on this policy, and if so, what is it?
Yes, we have taken a position in opposition to that proposal, and we've said before, the burden of medical costs on our members is significant. Half of them have an income of less than $23,500 a year, and they pay, on average, that group pays $4,000 for medical costs. Also, as Medicare premiums, Part B, are raised, they pay those increases. So imposing yet another deductible increase or expense on this group is really, we think, unaffordable, and we think there are far better ways to restrain costs in health care in general and in the Medicare program in particular than raising premiums or deductibles.
And Dr. McEnany.
Thank you for the question. We don't have any immediate policy on the President's budget proposal that we just heard on the State of the Union very, very recently. But we do have policy that we want to help consumers, our patients, to spend wisely and make wise choices. Many of our specialty societies have adopted programs that we work with on choosing wisely to use those procedures that are helpful and not use the ones that are not needed or could be avoided. There's literature that deductibles and copays can both decrease access to useful care as well as unuseful care. So we think that this is going to be a more complicated issue. We'll be happy to get back to you on that and work our way through that.
I appreciate that very much. Appreciate your testimony, and I yield back.
Thank you. The gentleman's time has expired. All members seeking recognition